हेलो हेलो हेलो।
बस बस।
Hello, hello, hello. Check, check. Hello, check.
We can start, ma'am.
Good evening, everyone. So today we are here with the third webinar of our comprehensive master course in breast cancer. And we have come today with a very important topic, that is image-guided breast interventions. Really, it is very important in the diagnostic arena of breast cancer to have a precise diagnosis. Without wasting much time, I would like to call upon Dr. Rajiv Agarwal. Sir is Senior Director Breast Surgery at Medanta, Gurgaon, to give the welcome address. Over to you, sir.
Thanks, Prekshi. Good evening to all of you. Uh, the focus studies in breast cancer now almost 4 years old, more than 4 years. Almost 35, 40 webinars, and now we are doing this master class, which is third in the series. And today we are starting with the radiology. Today, radiologist has become an essential part of the breast clinic uh, because any breast diagnosis starts from the radiology department, and we have today a couple of speakers who are one of the best in their own field. So, without wasting much time, I welcome my speakers and all the delegates who have made these seminars a grand success. Over to you, Prekshi. Thank you very much.
Thank you, sir. So we'll start with the modality, which is the most commonly used modality, that is ultrasound for any breast cancer related intervention. And for that, we have Dr. Jivitesh Thoda. He is consultant, Department of Radiology at TMC, Kolkata. Over to you, Dr. Jivitesh.
Uh, Thank you, ma'am. Thank you, sir, for having me. So, I'll be presenting my, I'll just go to the screen share one. So, is it
Yeah, visible.
visible?
Yeah.
Okay.
Please keep it on slideshow. Yeah, it is there.
It's there.
Done.
Right. All right. Good evening, everyone. So, I'll be discussing the modern breast interventions with ultrasound guidance. And my name is Jivitesh Khoda, and I am a diagnostic and interventional radiologist in Tata Medical Center. Most of my work is in interventional radiology, but I'll speak on some of the interventions which we do in breast as well. So the first and foremost thing which we do for which the patients come to the radiology department is the breast biopsy. From the moment the suspicion of cancer starts, any breast lump presents or any diagnostic need is there, the first thing patient will undergo after diagnostic workup will be a biopsy of the lesion. So that is the histopathological. It is the gold standard for histopathological diagnosis, and is performed under real-time ultrasound guidance. And the biopsy guns commonly used are of 14 to 16 gauge with a coaxial system, and the length is usually of 10 centimeter. The positivity rate for both 14 and 16 are comparable, though 14 has a slightly higher accuracy than 16, but very minute differences there, so either can be used. And usually 3 to 5 cores are sufficient when you are taking the samples. And before starting the procedure, we give a local anesthesia. Usually 10 to 15 ml is usually enough, and the coaxial is inserted till the lesion. And multiple cores can be taken then from that position by manipulating the coaxial in upward and downward direction. So the image below shows a 16 gauge biopsy gun, automatic gun. The image on the right shows the loading area where the sample tissue is taken. In between this is from where the tissue core will go. And automatic guns are usually preferred in most of the cases, although semi-automatic can be used where you have to manually push the cutting edge ahead and take a sample. But sometimes some lesions, breast lesions, especially when the lesions might turn out to be fibroadenoma, they can be very hard, and piercing them can be difficult sometimes manually. So at least in my practice, I have found that automatic can be very helpful and doesn't provide any difficulty and doesn't have any difficulty in piercing these hard lesions as well. So just a small video how this is loaded like this. Both the things are loaded, and then a shoot is taken like this. So as soon as you take the shoot, the sample is loaded within the loading area which I had shown before. And the coaxial system is like this. If you see, this is the coaxial, the inner stellate is taken out once you reach the lesion. And then you again load the gun as shown previously, insert it into the coaxial, and then you take a shoot, right? So it goes ahead, and it is usually a 2 centimeter shoot, meaning like where the point of your coaxial is. I'll go to the next image. So this is the lesion on the left, and your coaxial will be here somewhere. So this lesion is probably not shown a measurement, but looking at it, it's probably around 2 centimeters or slightly more. And whenever you take a shoot, a 2 centimeter core will come. There are systems to take smaller samples as well, like 1 centimeter as well. There are sometimes adapters given with this coaxial where you can reduce the shooting area. This can be helpful in small lesions where like 1 centimeter lesions or maybe sub-centimeter lesion where you don't want to take full 2 centimeter core unnecessarily from the normal breast parenchyma. So um, it is accurate. So in short, the procedure is very accurate in providing the tissue, and the complications are minimal, like bleeding and local infections. These can be easily managed, not a thing of concern, because breast is I mean, it's not some deep organ. If some bleeding even happens, just press it for 10 minutes, not a big issue. 10 minutes for arterial bleeds. And if there's a venous bleed and you feel some oozing is still going on, you can always give some PAUSE 500 IV. And for arterial bleed, best thing is to compress for 10 minutes and put a tight dressing with a gauze ball and just fix it with Dynaplast. And usually it's not a concern. At least I have not seen any significant complication, any hematoma which has caused some serious problem. The small hematoma which form are usually nothing to be bothered with. And it's excellent for targeting lymph nodes as well. Although I'll get to FNAC, as that is very commonly used in most of the institutions for lymph node, but it's been shown that the sensitivity and specificity of core needle biopsy is higher than lymph nodes, so it's excellent for that as well. Only some of the limitations which might be there are like 2 to 4% of the cases might have a repeat biopsy due to erroneous targeting. Why this erroneous targeting can happen is some lesions which are poorly visualized on ultrasound. And for those cases, you might choose alternate modalities, which my colleagues will come to, like stereotactic and mammography or MR guided, if not even seen on mammography. So in those cases, if not properly targeted due to limited visualization on ultrasound, then you might get a false result. And cases where benign and malignant tissues are intermixed, like DCIS, lobular invasive cancer or invasive ductal cancer, where it's not a completely invasive carcinoma, which you have a well-formed cancer. In these cases, sometimes benign tissue also gets intermixed. And as you know, like only part of the area is sampled because you cannot sample the entire tissue. So if you're unlucky, you might end up targeting an area which contains more of the benign tissue, and you might miss the malignant tissue in those cases. And it's been shown that around 10 to 50, from 10 to even up to 50% cases of Barrett's lesion can eventually turn out to be malignant, which have been sampled with core needle biopsy, again due to the underestimation on pathology. And 25% of DCIS cases on core nodal biopsy will have some invasive component on surgery, again because due to limited targeting of a core nodal biopsy. Again, so a lot of these studies which have shown these percentages are where the samples have been taken from one region only. I mean, usually now a lot of people use coaxial. There you can target multiple areas within the lesion. So you will get more tissue and a better area, representative area from the lesion, and better chance of getting a positive result if that is the case. So now next, moving on to vacuum assisted biopsy after the core needle biopsy. The main advantage of this procedure is that you can take a lot more tissue, and the representative area is more likely to get targeted with a vacuum assisted biopsy. Most commonly 10 to 12 gauge needles are used. Again, the 10 gauge is the larger one, 12 is the smaller one. As it goes with all biopsy, the larger gauge you use, your accuracy will keep going up. Even 7 gauge systems are there, but at some point the risk of injuries are more, and there's enough data to show that with 10, even with 10 gauge, you get a good amount of accuracy, and going beyond that does not provide any additional benefit in your sensitivity and specificity. And the mechanism is basically you just position the needle below the lesion, and a vacuum system is there, which and rotating blades or cutting blades, depending on kind of biopsy the manufacturer using. They cut these blades, or the blades cut the tissue, and the vacuum system suction the tissue and pushes it behind, and you can get multiple cores with a single pass into the lesion. And more often than not, then you are more likely to get a positive result with this. And even a marker can be placed via the same needle at the end of the procedure. So both things can be taken care of in a single sitting. So it helps in excision of complete lesions. As I mentioned, since it takes more tissue, can remove small benign lesions like fibroadenoma. Usually, ideal size is 3 centimeters, but the 3 to 5 centimeters. The recommendation is between that. Anything larger than that, the multiple targeting then will have to be done, and it's not usually recommended. And that is as per the guideline, and useful for suspicious calcification, which are poorly targeted on core needle biopsies. I mean, which, like I said, any suspicious calcification which you're seeing there, which might represent DCIS, which is not formed a well-formed lesion on ultrasound, you might miss it. So that can be targeted on VAB, and any architectural distortion and B3 lesion, as mentioned earlier, with core needle biopsy, anywhere from 10 to 50% might eventually turn out to be malignant. So in these cases, this is very useful. Again, because the gauge is more, it's a bigger needle, the risk of bleeding is more in this case. With this procedure, again, can be easily managed, not a big deal. But on day-to-day practice, we usually use core needle biopsies only, unless there is specific indication as listed here. Otherwise, the daily practice is to do a core needle biopsy for all lesions. So, moving on to fine needle aspiration cytology. So usually 20 to 22 gauge needles are commonly used. Um, it is mostly still being used in lymph node it's mostly being used to assess the lymph node, whether it is involved by metastatic deposits or not, and its role in primary lesion. For the histopathology of primary lesion is very limited now. It's mostly outdated because now you have a core needle biopsy at your disposal, and no significant complications are there. And with the FNAC, the sensitivity and specificity are much lower compared to core needle biopsy. So really not much use of doing it in solid lesions. Can be done in cystic lesions where you want to send the fluid for cytology. There, I mean, you can aspirate and send it. That's probably the only use. And in lymph nodes, a lot of, centers are still using FNAC for lymph node, but even biopsy can be done either way. So then moving on to wire localization. So preoperative localization of non-palpable breast mass is the primary indication for this. If usually post chemotherapy, these patients come post chemotherapy, and there is significant shrinkage in the mass before the surgery, and usually a wire localization which is done, which I'll get to in a bit. The target is usually to put the wire near the marker, and if the lesion is visualized, then at the center of the lesion, and if there is a near complete response as seen in a lot of cases, then just place the tip of the wire near the fiducial marker. So marker can be placed under ultrasound and mammographic guidance. So if you're able to localize the marker well on ultrasound, then it can be done there. But if there's some confusion that you're not able to see the marker and the disease is completely gone now and you're not sure, it's better to do under stereotactic mammography in under mammography guidance, so that you don't put the wire somewhere else. Because once you unload the wire into the lesion, you cannot just retract it. Then unnecessarily you'll have to put another wire if turns out that you've put it in the wrong area. So only if you're very sure on ultrasound that properly located the lesion or the marker, then only deploy it under ultrasound guidance. So the procedure is simple. It's a 20 gauge needle with 10.7 centimeter length. So that needle, as shown in this image, is you pierce the lesion and reach the distal edge of the lesion, and then you just simply retract the needle which contains the wire. So wire, I mean there are two. I mean the one is the barred one, and which is one is the cap-on one, which are commonly used. This is a cap-on one which has a J-shaped tip, and it just opens up and this usually latches onto the lesion here and then stays in place. Then you cannot move it once you have retracted the needle after the hook has been deployed. So any adjustments you want to do it before retracting the needle. After that, it's not possible. So now we are using, so commonly we are doing it on the day of the surgery early in the morning, because previous day we've seen, like if we admit the patient previous day, a lot of movements take place and inevitably something or the other will, some movement, some pushing here, there will happen. And a lot of time these wires get displaced then eventually by the morning. So right before the surgery, we try and put the wire at that time, and the wire which remains outside the breast, the part which remains outside, is just carefully coiled up and covered with gauze and micropore so that it's not displaced while transporting the patient to the OT. And one problem which we see, I mean, I don't know about all the institutes, but commonly we see is that in patients with a complete response, like I mentioned earlier, there is not enough hard tissue for the wire to latch onto. And once you deploy it, and once you, especially in stereotactic one where the compression is applied over the breast, once that compression is released, sometimes the wire gets displaced. That's problem is not as common in ultrasound. So in complete response, some displacement might happen. So so this is the other wire which I was talking about. So this wire is the barred one, which has two hooks at the end, unlike the previous one which has one hook. We've seen it latches on slightly better, and the displacements are less in this case. So both the wires have certain markers in place to help the surgeon, because we are with the help of this coaxial, we are able to with the help of the coaxial, we are able to tell the depth clearly, but the surgeon might have a difficulty in telling the depth. So here, like for example, in this wire, the uh, the thick metal part which you see up till this black point here is 12 centimeter, and the black part which is slightly thinner posterior to this is 7 centimeter, 19 centimeter total length. This is just for a visual aid, so that the surgeon, when he is going, I mean, into the breast, he knows how deep he's going and he has a good idea about that. This is all mentioned in the along with the manual of the wire, so that it can be looked up there also. This is just one mammography image I'm showing. Once it's deployed, this is how the hook looks like near the marker. Here you can see there is no lesion left. It is almost a complete response. So this is the only place where you can deploy the wire. So this is the other cap-on one which I said, which is a single hook. It has a slightly higher tendency to get displaced in my experience, and this is how it looks like once it's deployed. And like I mentioned earlier, here there is a complete response around this fiducial marker. So once the specimen reaches us, you can see that there is quite a bit of displacement of the wire tip from the marker where it was originally put, just because there was not a good solid anchoring for the wire. It moved a lot, so this can happen. And Usually we take a post wire insertion mammographic image, check image, and if there's any significant displacement, we usually call up the surgeon to let him or her know, and we give a approximate centimeter distance of the wire tip from the marker. Not very ideal, but that is the best we can do rather than keeping the surgeon completely unaware of the situation. So, another thing which can not very common, but depending on the situation, bracketing can be done. And this is usually for like in this case there was a large mass here and a satellite nodule here. So this is post chemo before the surgery, so the lesions are not well appreciated now. So in these cases, for large masses, for nodules adjacent to mass, large areas of calcification, where a single point of localization will not be helpful, there you can do bracketing, in which in case of the large mass or the large calcification, the wires are placed on the outer edges of the area that needs to be operated out, so that the surgeon gets to know that from this area to this area and between the wires is the area which I need to operate. So another thing, though not, I don't think it is available in India yet, but outside in other countries like UK, this is catching on. Like a non-wire localization techniques like MagSeed is there in UK with a magnetic seed marker. It does not get displaced, and before seeds, even like right up till the day of surgery, can be placed at any time, even if there's complete response. It's like a think of it as like a fiducial marker. It will be there, and there are detectors which can detect the magnet. And recent data has shown that it reduces the surgery time and is more accurate in pinpointing the lesion compared to conventional wire techniques. So then moving on to fiducial marker placement. So approach is again similar to biopsy. Lesion is approached after giving local anesthesia, usually 10 to 15 ml. The needle is a 17 gauge, 12 centimeter long nodule, and the marker which is deployed is 3 millimeter, and is ideally it should be deployed in the center of the lesion. It is usually made of gold and titanium, and which makes it a non-reactive metal for MRIs. It's not so that there is no contraindication for that. So the one which we use in our department is an ultra dual trigger, again barred equipment. It's very simple. Again, it has gauged, the needle is gauged with 1 centimeter marks. And once you reach up to the area of interest, you just have to push this pink button behind, and it just pushes the fiducial marker head as shown in this image. This is the needle which is reached here. And once it is deployed, you can see it is a bright ecogenic thing in the center of the lesion. This is the fiducial marker which has been deployed. Later on, during localization, when the lesion shrinks, sometimes it can be difficult to detect, but if you have a keen eye, this can be picked up even on ultrasounds, and you can do localization even then, even in the presence of a complete response. So therapeutic interventions usually, this is more of I would say, at an experimental stage. Ultrasound cryoablation, there is some data on microwave ablations also, but cryoablation is going to be more promising. And it is usually used for small tumors, fibroadenomas, less than 4 centimeters. So in some places, they are doing ablating these lesions using cryoablation. So as the name suggests, the process is that the area is frozen by this process, and ice ball forms around the lesion, and gradually it undergoes necrosis. So that is the mechanism of action. Usually it just freezes and necrosis is there. And for cancer treatment, it is still in experimental stage, and some trials are there which they have done in stage 4 patients in which surgery is obviously contraindicated. In those cases, they have done cryoablations of the primary lesions just to see how the response is. Again, data is very limited on it, and it's not a method of treatment. But for benign lesions, if you're targeting those lesions, they ideally should be well defined, so that because for ablation, there is a defined zone which you can select how much of the zone you want to ablate. If the lesion is well defined, only then you will know how much area you want to ablate. If you cannot even see the lesion properly, then don't ablate, because you will either under ablate or unnecessarily over ablate. the area. And usually it's ideal that it is 5 to 10 millimeters away from the skin surface and chest wall, because you might cause the frostbite injuries to these areas, and it can be difficult to heal then. And the lesions, as mentioned earlier, the mechanism is that they undergo necrosis due to freezing eventually. And the limitations mostly are that it's very expensive. In India, each needle, it's a non-reusable needle which goes into the cryoablation machine, and each needle can, at least in India, can cost up to 2 lakhs for each needle. The entire procedure cost can quickly go up. And again, as mentioned, if not adequate distance, if not maintained, frostbite injury to skin and chest wall can occur as well. So, last but not exactly for cancer, but in some cases, like if you have benign abscesses, you can either aspirate it or put a pigtail in it. 8 French 30-centimeter pigtail is usually ideal to drain these abscess. And large cysts which cause discomfort to the patient, and it's proven that they are benign and there's no associated cancer, they can be aspirated. And if the cysts are recurrent and painful, again, in those cases, if surgery, I mean, for whatever reason, cannot be done, in those cases, there's even an option of alcohol ablation. 99% ethanol is used in that, and just have to aspirate the cyst and put some alcohol in that. And it's been shown that 90%, 97% of the patient have complete response in those cysts, and they don't usually recur. So, this is these were the points I was covering, and that usually covers most of the things which fall under the spectrum of ultrasound. Thank you.
Thank you, Dr. Jivitesh. That was a wonderful presentation. I request you to please stay over till the end to address the questions.
Yes.
And my request to the delegates, please put your answer questions in the QA box. We will address all the questions at the end of all the sessions. So now we'll be moving towards our next session. So suppose there is a lesion which is visible on mammography only and not visible on ultrasound. How to go ahead in such a case? It will be addressed by Dr. Prerna in her talk. She's consultant at Department of Radiology, RGCI Delhi. Over to you, Dr. Prerna.
I thank you all for having me here today. So the topic that I will be covering today, can you see the slides?
No, not yet.
Oh, just a minute. Yeah. Can you see the
It's
slides
there.
now?
Yeah, it's there.
Okay. So it's a very dry topic, very mechanical, and it's very difficult to understand and explain. But so there we are. I'll just start with the the stereotactic, an overview of stereotactic breast procedures, and I'll begin with what is stereotaxy. Then go ahead and discuss the basics, and then let's look at the some procedures that we routinely perform. So what exactly is stereotaxy? I'm unable to change my slides. Okay, great. Yeah, I can. So what exactly is stereotaxy? So breast is a mammogram is a 2D representation of a 3D structure. So after placing the mammogram, in the mammogram, we can easily see the X and the Y coordinates, but we don't know the depths. And so in order to calculate the depth, the procedure of stereotaxis is used. We take two images at plus 15 degree and minus 15 degree. And the shift of the image, which is also known as the parallax shift, is used to calculate the depth of the lesion. So based on the shift of the image, the depth of the lesion is calculated, and that is stereotaxis. So what are the equipment that we need? We need a stereotactic unit, a device for patient positioning, the monitor, and the biopsy equipment. So there can be two types of equipment. One can be the prone equipment, wherein the patient lies down on the bed, and all the operator is doing the procedure under the couch. There's a 360-degree axis to the lesions all around the breast. However, the deep lesions cannot be biopsied easily, and it's a very expensive system. The one which we routinely use is a add-on unit, which is attached to the conventional mammography unit and converts it into a stereotactic biopsy machine. The patient needs to be comfortable, so there needs to be a recliner, and the patient can be, sat on a recliner for the duration of the study. Then the monitor, which will help us calculate the depth of the lesion based on the principle of stereotaxis. Then before starting the procedure, any kind of stereotactic procedure on the stereotactic unit, you need to do a quality control to ensure the lesion is targeted adequately. So this is the most important thing, identifying the view in which the procedure is to be done. So what happens is it is very easy to get carried away after placing the patient in the biopsy unit to, it's basically selection of coordinates, and it is a very mechanical procedure. So it is very easy to get carried away, especially while placing the wires. You might end up placing a wire for a lesion which is in the inferior quadrants with the skin entry point in the superior quadrants. So you will have a lesion in the lower quadrants and a very weird skin entry side which is somewhere superiorly. So we want to avoid that, and it is very embarrassing. So we need to avoid that. We need to make sure that the skin entry side is as close to the lesion as possible, or as close to the clip as possible, and in the same quadrant as the lesion. So to ensure that we can have a variety of placements, which includes a craniocaudal, mediolateral, lateromedial, and so on. And the direction of compression is based on the breast visualization of the lesion, the location of the lesion, and the size of the breast. I will just tell you with a few examples. So suppose in this, we see that there is a lesion in the upper outer quadrant. So in the CC view, we see that the lesion to the skin, to the outer edge of the skin is the least. All right. So the biopsy window should be lateral, as in this way. The needle should enter from the lateral side in the upper outer quadrant region. Similarly here, the lesion is in the lower quadrants. So here, if we try to place the needle from top to bottom, we'll have a very different entry side, right? So we can actually make the patient lie down on the couch and introduce the needle from inferiorly. Similarly, here we see that the lesion is more in the inferior quadrants. Either we can use this approach, or we can also use a mediolateral approach. That is, the biopsy window is medially. So we need to be, we need to be in sync with our surgeons before placing the wires, because you might have a skin entry site in Tokyo and the lesion in London, and it's all very confusing then. So we need to make sure that we know where the skin incision is going to be, and we need to make sure that that entry site is as close to the lesion as possible. So now, as Dr. Jivitesh has already said, that there will be lesions which have already got completely resolved with some, with nothing seen on ultrasound, and we need to place wires. So one such case is this. Here we see that the clip is almost equidistant from both the edges. But here we can see that it is closer to the superior edge. So the wire can be placed in a craniocaudal direction. Similarly with this, the wire in this case will also be placed in a craniocaudal direction. Again, this lesion is far off from the lateral edge, but closer to the medial edge. So the wire can be placed from mediolateral. Another case, the lesion is bank central, but we see here that the lesion is closer to the lower edge. Here in this case, as I had shown earlier, we can have an inferior approach. So we need to just make adjustments and improvise based on the location of the lesion. Now let's go back to the steps of procedure again. Here we see, I don't know if you can appreciate, there is some microcalcification here, and we need to target this. So we can select any of these because we need to biopsy this. So we can select either the 14-gauge biopsy gun, as Dr. Jivitesh had already explained, or we can use a VAP equipment for the biopsy. Then the first thing that is done is take a stereo pair, as in first it will be a 0 degree without angulation with the arm being straight. And then you have a plus 15 degree angulation and a minus 15 degree angulation. So these are the two views that you get with the angulation. Thereafter, you select the target. If you can see these targets here, this target has been selected on the screen. Thereafter, after selecting the target, the screen, we need to select the biopsy equipment that we are going to use. So here we see that the biopsy equipment has been selected and the target lesion lies within the notch. Then we need to add at the patient end, we need to make these, these slots which are there for the biopsy guides or the biopsy guides that are there that need to be inserted in the biopsy arm. The XYZ coordinates are then calculated and sent to the machine. Here we see that the patient has been positioned. This is the biopsy gun, the compression paddle, the detector plate, and the compression has been applied. You give local anesthesia. You do a localized, as in a superficial infiltration as well as deep infiltration, then give a small nick. Then advance the needle, the selected target to the selected target. And then take pre-fire and post-fire to check if the lesion has been adequately sampled. Take a biopsy specimen, insert a marker clip, and your procedure is done. So few challenges that we face with stereotactic procedures are you might have not enough margin below the tip of the needle and will lead to damage to the detector, and that can be avoided by using air gaps or bolstering the breast. At times, the lesion may be very superficial, and in that case, you may use a plastic aperture cover, or you may use half notch, or you may raise the skin by giving saline injections. So some common procedures that we do with stereotactic biopsy are location of the area that you have recently biopsied, or in case the lesion is not very apparent on an ultrasound, you might want to place a clip prior to starting the NSCT or to mark a node. So these are the examples here. We are seeing clips for marking the lesion, clips for marking the nodes, and if you're marking more than one lesion, you need to use different shapes of the needles. So wire localization indications are the non-palpable lesions, the post-NSCT non-palpable lesions, and microcalcification only lesions. With wire localizations, we have to be very careful. As I said earlier, we need to introduce the wire, the skin entry site needs to be in the same quadrant. Otherwise, it's very haywire and you need to be in sync with your surgeons for the same. Here are a few examples. Here we see that there is a clip which has been with a dual lock wire. It has been marked with a dual lock wire. We do all these procedures in the morning before the surgery. So bracketing, as Dr. Jivitesh had briefly spoken about bracketing. So in bracketing is mainly for ensuring that all the microcalcification that is present has been adequately, to ensure that it is completely excised. We place two wires, one in superior inferior and the other one to mark the lateral extent. And based on these, the distances are calculated on the mammography. Then you take a specimen mammogram to confirm that all the microcalcifications have been removed. So here we see one case, we had placed a wire on the ultrasound because we could see this big clip, big coil. But then we realized that there are a lot of microcalcifications in the vicinity. So we took the patient into the stereotactic unit and placed the wires, placed multiple wires. This was the final specimen mammogram. We can see that the excision has been carried out all along the clips, all along the wires, and the calcification has been included completely. VAB can also be done in stereotactic guidance. The concepts are the same. It's primarily used for rat pad discordance because if you have lesions where you are, which you are suspecting to be malignant, but you are getting a negative pathology in those lesions, you might want to perform a VAB to get a better sample. In microcalcification only lesions, for fibroadenomas, as Dr. Jivitesh said earlier, and papillomas. Now, I would like to show you a case of VAB that we did. So there was this young lady around 35 years of age, post-treatment, post-BCS for triple negative breast cancer. She was on surveillance, and on surveillance, we detected this calcification. Initially, we thought it is all dystrophic developing calcification, and we thought that we can observe it, but suddenly we were not very comfortable. So we did a VAB for this lesion. We have extracted the specimen mammogram, which shows calcifications, and this turned out to be a DCIS. So yes, we get surprises. Similarly, another lesion, microcalcification only lesion, a biopsy was done and we see calcification in the specimen mammogram, and this was also DCIS. So let's discuss a few recent advances. One would be use of tomoguidance. Tomography is basically a stack of thin images are acquired sequentially in the breast, and it will at the site of the lesion, the margins of the lesions will be very conspicuous. So we can use that for doing a biopsy as well. The slice on which the lesion is best appreciated is selected and targeted. So, but however, there is no significant difference in the initial malignancy rate or malignancy upgrade rates with the tomogram. Similarly, contrast-enhanced mammogram can also be used, wherein the contrast images are used for targeting the lesion. The new hardware, I assume, will be discussed subsequently. For localization, will be discussed subsequently. So thank you for your attention. And if you have any questions, you can ask me right away or later.
Thank you, Dr. Prerna. So great presentation. Questions will be taking up at the end of all the sessions. So my request to you also to please stay. So now we'll be moving towards our next session, and it will be regarding MRI guided breast interventions. To take this session, I would request Dr. Seema Sood. Ma'am is a chairperson at the Department of Radiology at Sir Gangaram Hospital, Delhi. Over to you, ma'am.
Thank you so much. Is my presentation visible?
Yeah, yes.
Okay. So I'm going to be talking on MR-guided breast interventions, the indications, techniques, and challenges. So we all know that MRI of the breast is one of the most sensitive tests for detecting breast cancer, and it identifies lesions that other diagnostic tools may miss. But despite its high sensitivity, it's not very specific, and sometimes we do have a problem differentiating benign from malignant masses, and consequently, of course, biopsies are essential to confirm the diagnosis. So when do we do MR-guided biopsy? So if there is a lesion which is a BIRADS 4 or a BIRADS 5 on MRI, we always do a second look ultrasound or mammography to see if the lesion is visible on any other modality. And if the lesion is detected on ultrasound or mammography, then we sample using that modality. If only it is not seen on ultrasound or mammography, that is when we do a MR-guided biopsy. So why do we do a second look ultrasound? Because ultrasound is the easiest way to biopsy any concerning lesions. But you have to be very careful when you're correlating lesions seen on MR with ultrasound, because MR is done in the prone position and ultrasound in the supine position. And if you're not sure, a clip should be left in place and you should repeat an MR before you actually go ahead and biopsy doing ultrasound guidance. So here's an example of a case. On MR, we found this non-mass enhancement. On ultrasound, a second look ultrasound, it was, we thought this was the lesion which was actually the malignancy, but we were not very sure. So we went ahead, placed a clip, and did another short sequence MR, just the contrast. So you can see this is the clip, and the lesion which is enhancing is away from the lesion, from the clip. So this was not actually correlating, and she went in for a breast MR guided biopsy, and this turned out to be a DCIS. So when do we do a MR guided biopsy? Like I told you, if there's a BIRADS 4 or a 5 lesion seen on MR but not seen on second look ultrasound, then an MR guided biopsy is indicated. Other indications include any small mass less than 8 mm, presence of non-mass enhancement not seen on mammography, a complex breast pathology or anatomy, if the breasts are very large and it's difficult to biopsy under ultrasound guidance, and also if there are multiple lesions. So let me show you a few examples. This was a biopsy-proven case of lobular carcinoma done under ultrasound guidance. On MR to look for extent of disease, we found another lesion in a different quadrant. And this was biopsied, and this was also proven to be lobular carcinoma. The second case, there are multiple cysts, and adjoining these cysts, you'll also find an area of non-mass enhancement, and this on biopsy also turned out to be DCIS. So these are the conditions where you'll always go in for a MR-guided biopsy. And of course, like I told you, non-mass enhancement not seen on any other modality, we need to do MR-guided biopsies for these patients. So you've been told by the previous two speakers, and you got a little overview of what is VAB. VAB is basically vacuum-assisted breast biopsy, and in MR, we always prefer to do this instead of just a core biopsy, because we want to actually get a lot of tissue which we can give for sampling. VAB can be done under any modality, but that is ultrasound, mammography, and MR. In MR, it's preferred. Like I told you, it's a procedure which is an expensive procedure, so we want adequate sample should be there. So the difference between a FNAC, core biopsy, and VAB is that you get a large tissue volume, the sample size is large, so the histological accuracy is much higher than a core biopsy or an FNAC. It's excellent to, like what Dr. Prerna showed you, for microcalcifications. And also it can be used for removal of small fibroadenoma. So you can have therapeutic removal under ultrasound guidance. The contraindications for MR-guided VAB are the same for any other biopsy procedure. You have the absolute and relative contraindications. Any bleeding disorder is an absolute contraindication. And if a patient has any implant which is not MR compatible, we can't go ahead with the MR-guided VAB procedure. So let's move on to the technology and the technique. So we're using the VAB, and the needle size is typically between 7 gauge and 11 gauge. What we are using is 10 gauge needle. And what do we require for a biopsy? You'll require a MR compatible device. We have a BARD device. It looks like this. This stays outside the MR room and is connected to the MR compatible driver by a long tubing. Then a breast coil, biopsy coil, is absolutely essential. And this has these two grids on either side, which you compress the breast with. And you need MR compatible biopsy clips to be placed post the procedure. For the biopsy itself, you need the coaxial introducer set, which includes a plastic sheath. And this has a stopper in this where you can mark the depth where you want to go. A titanium stylet, which is placed into this to puncture the skin. A obturator where you have to see where exactly you are to localize. And we have this needle grid or a grid block. I'll show you how we use these. So first, when the patient is taken, you prepare the patient. The breast is cleaned with spirit and betadine. And then the patient is made to lie prone with the breast hanging inside the breast coil. And you have this grid, what I told you. In this grid, there are multiple holes. Each is 1 centimeter by 1 centimeter. And we have this fiducial marker. So what we do, we take diluted gadolinium and put it into this fiducial marker. So it's a reference point where we are. Then the breast is compressed. The compression is very, very essential, because if you do not, you over compress, the contrast will not go in when you're giving contrast and the lesion will not be visible. If you under compress, the skin will buckle and you will not be able to target properly. So how do we see how much compression we need to give? If you approximate your middle finger and the thumb together and feel the thenar eminence, the amount of hardness or the plumpiness you feel, that much is how you must compress the breast. And the other thing you need to remember, when you compress the breast, the shape of the breast will change. This is a diagnostic MR, and when you compress, look how the shape is changing. So you need to correlate what you saw in your diagnostic MR and on the time of the biopsy, that you are biopsying the right area, because if the breast is getting a little distorted. So what do we do after placing the patient in the breast coil? You see, this is the fiducial marker which we had placed. So the grid, we basically number A to E and A1 to A8, like you have these numbering. So we put the fiducial marker in the B6. So all we have to do is tell the software or the computer, the workstation, that the fiducial marker is placed in B6. You can place it anywhere. And then when you give contrast, you put another ROI on the contrast, the target lesion, and the machine will automatically tell you that you have to go in through this grid. So it's localized for you in comparison to the fiducial marker. And then to narrow that further down, we have what we call is the grid block. So this I told you, each square is 1 centimeter by 1 centimeter. So even to make it even smaller and make it more precise, we have this grid block which has these multiple holes. So the machine itself will tell you how you're supposed to place this grid block. Here it's showing you that it has to be placed with the 3 dots on top, and the bigger one, the one here where we have to enter, is the part where we have to put the trocar in. It also tells you the exact depth. So you can mark this exact depth, and you can target the lesion down to 1 to 2 mm. So just to show you what we've done, the grid is now being put, the grid block. We know we have to go through this particular hole. You mark the distance on your introducer sheath. You give local anesthesia, puncture the skin with the trocar. You remove the trocar and introduce the obturator and take another check cut. So now, after we've introduced the the obturator, you can see we are right at the target. So you've taken a check cut, and after you've done this, you remove the obturator, put in the MR compatible drive, and you just have to press a button, and the machine will automatically cut in all quadrants. So it goes 360 degrees around. So this is one complete circle. You can even take 2 circles. And after you've done this, we need to place the clip. We use the ultra clip, and you can see the clip has been placed at the site of the biopsy. So this is how we do the whole procedure. Then the patient, before taking the patient out, we do check cuts to look for any hematoma. And this is followed by sternly strips to oppose the margin where you've entered, and you give a compression bandage for 24 hours. We keep the patient in the MR suite for an hour just to see if the patient has any discomfort. There are very few complications which are really known. It can be hematoma, infection, skin bruising, pain, very, very rare pneumothorax, and you have to give proper post-procedural care instructions to the patient. The next day, we call the patient back and we do a check mammogram, basically to see where the clip is. And this is how the clip will look on mammogram. And the most important thing is you must always see the pathology report, because you need to know, is there any rad path discordance? And if your biopsy has been done okay, or do you want to repeat the biopsy? So this is how the procedure is done. I'm going to now move on to the cases and show you how the challenges we faced. So this was a 55-year-old female. She had had a history of mastectomy on the right side for DCIS 2 years back. So she was a high-risk screening coming to us for an MRI routinely. And 2 years post the mastectomy on the right side, we found this area of non-mass enhancement. You can see this is hardly 1 centimeter. So to do a biopsy of the central breast with adequate distance from the skin is the easiest biopsy we do. So this was basically a plain vanilla case. And post biopsy compression, you can see the breast is getting distorted. And the biopsy was taken, and post biopsy, the check showed there was no hematoma. And this turned out to be ductal carcinoma in situ. So this is the easiest case you can get, where the lesion is in the middle third depth with away from the skin. So this has really no problem. However, look at this case. This was a 51-year-old female who had actually just a boil on the right breast, and she was being screened for that. And on that, after mammogram, they found some area suspicious here, and they asked us to do an MR. And on MR, we find this area of non-mass enhancement, which is quite segmental in distribution. So this was worrisome for malignancy. She had no family history. And so this was we decided to do a MR guided biopsy. So lesions like this, which are in the anterior third of the breast and close to the nipple, are basically a little difficult to biopsy. The reason is, when you suspend the breast, this area lies free. So it's when you put in the trocar, the nipple and the breast will move. So what you need to do in these cases, which are close to the nipple, you should basically put a little support on the other side so that the nipple is brought right next to the grid and it does not move. The other thing you can do is you can inject some local anesthesia more towards the skin and increase the distance and go along the posterior margin like what we have done. Because once the needle is in place, the machine, it will cut full 360 degrees, and it has a 1 centimeter throw. So we know we will get sample from this tissue. So this is how you overcome any challenges you face because of the lesion being close to the nipple and close to the skin surface. And this turned out to be just usual ductal hyperplasia. Next case is a 73-year-old female who had complaints of pain in the left breast. She also had history of DCIS of the left breast. And this was, we didn't have the details, but she had breast conservative surgery in 2002. So we're talking about as 23 years back, and this was followed by radiotherapy. So she had a family history of breast carcinoma. And you can see here where the radiotherapy was given, there's a lot of calcification, the breast is hard. The same thing you can see on MR, this area of dark signal is all calcification. And there's disfigurement, you can see the nipple has moved up. So breasts like these can be pretty difficult to biopsy. And when we did her MR, we found this area of non-mass enhancement in the same site which she was operated. On a second look ultrasound, this was not seen, so we had to go in for a MR guided biopsy. So when we did the compression, we could see this area of non-mass enhancement. We did go in, but I think we were not adequately there because even the post biopsy clip was a little displaced. And when we got the final report, it said there was largely hemorrhagic tissue and very scanty or paucicellular stroma, and they were not able to give us an opinion. So now we knew we have to go in and again either re-biopsy and see what we need to do or have we left any tissue behind. So just to show you what this top row is her MR done prior to the biopsy where we found the non-mass enhancement. And when we did this second MR with only contrast, and we can see there is the tissue has become smaller, but there is definitely residual tissue in the same site which we had biopsied. So that means our sampling was not correct and we had not done it right. This was because the breast was so hard, it was very difficult to negotiate the needle through the areas of calcification and fibrosis. So she opted not to go in for a repeat MR guided biopsy. She wanted this lesion irrespective to be removed. So we looked at the clip where we had placed, and you can see the enhancement was just posterior to the clip. So we were pretty sure when the surgeon goes in and takes out this tissue, he will get this enhancing focus also. And so on the day of the surgery, she had a hook wire placement. You've been told how the hook wires are placed. This is the clip we have put, and this was the hook wire placed, and this is the sample specimen radiograph, and you can see this whole tissue was removed, and this turned out to be DCIS. So sometimes when you have cases like this, you have to actually see what you can do, and like we did in our case, we repeated the MR, we looked at is there any residual lesion and how far is it from the clip, and so it was easy to remove for the surgeon. Another challenge we face on MR guided biopsies are these posteriorly placed lesions. What happens when you suspend the breast into the coil? And you can see this tissue is not getting actually suspended. The grid is only coming till here. So we would have not been able to sample this. So what do you do in these cases? You make the patient lie with the arm down and not in the head up position. That will make this lesion drop in more and also raise the contralateral side. So when you raise the contralateral side, this will drop in more. And now this came into the grid position and we could biopsy from here. And this was just a hemangioma. If you have very superficial lesions, you are scared because if you go from a medial to a lateral approach from here, you can puncture the skin and take a big chunk of the skin out when you are biopsying a superficial lesion. So we prefer to do a opposite side approach in these cases, like this was done. The other thing, if it's a very posterior medial lesion and you want to even go in from the lateral approach, what you do, you raise the same side up. Unlike the posterior lateral, we were raising the opposite side up. So this lesion is going to drop in and come into the area where you can biopsy it from. And this is how you counter lesions which are very posterior in the chest. For superficial lesions, you can do another thing. If you cannot go from the opposite side, you can use a petite needle where the aperture is smaller and even the surface is more blunt. So chances of taking a biopsy or pulling out the skin is lesser. You can also go beyond the lesion because this area is what is going to be sampled and not from here. And when you go beyond also, you will be able to get a sample from this lesion. And the other thing is when you give local anesthesia, you can give a lot of it on the skin to displace the lesion away from the skin surface. Another challenge you can face is when there are implants or you want to do a breast biopsy or bilateral breast. In cases of implant, what you need to do, just displace the implants posteriorly so that you are away from the implant and the chances of rupture are less. So in cases of implants, you must take a prior consent that the implant can rupture. The positioning is key in cases of breast implants, and you should basically displace them posteriorly. Sorry, should I carry on? And in case of bilateral breast biopsies, the planning again is essential, and because you have to biopsy both simultaneously, and in these cases, the approach can only be lateral to medial. So my take-home messages is that careful pre-biopsy planning is very, very essential. And positioning is the key to a successful biopsy. If your positioning is right, your compression is right, you will never go wrong. And the tips for challenging cases you have shown you when you have a superficial target, if lesions are close to the nipple, if they're posterolateral or posterior medial, and sometimes you can even have failed clip deployment. So if you have not been able to deploy it, do it under ultrasound guidance later. And very rarely, sometimes you do not see the lesion on the day of the biopsy because sometimes you can mistake hormonal changes for worrisome features. So in these cases, just a follow-up MRI is recommended. Thank you very much. This is my team, my receptionist, my nursing staff, my technician, and support from the bar. We do these biopsies together. Thank you very much.
Thank you, Dr. Seema, for that wonderful overview of MR-guided breast interventions. And also, thank you to you for sharing those, important tips for especially difficult locations where the biopsy can be a challenging procedure under MRI guidance. May I request you to stay with us for a little more time so that in case if there are any more questions related to your presentation, we will be happy to have you. Is
Yes,
that okay
surely.
for you?
Thank you very much.
Sure.
Absolutely. Thank you.
Thanks. Yeah. So we'll move on to our last topic, which is going to be taken by Dr. Aini Chogle. She's a trained breast surgeon, trained in India, and now she's moved to the UK for further training in breast cancer surgeries. She's going to talk to us about the non-wire, localization methods. Although we are presently using wire for localization of all the lesions, and other non-wire localization methods are yet to be introduced to our country, but I'm sure very soon we will have those technologies. So let us hear Dr. Aini out. Dr. Aini, next 15-20 minutes are all yours.
Thank you, Dr. Vishali. Thank you so much for the kind invitation. And thank you to Association of Breast Surgery of India and the Indian Anti-Cancer Trust. I'll just show my slides. I'd also like to thank all the speakers before me. I think I learned a lot today because when we are working, we're just scurrying around making sure that we finish doing all our jobs. But sometimes we don't have the opportunity to come across in the next room and see what you all are doing. So thank you so much for your excellent presence. I'm going to speak about Beyond the Wire.
Dr. Aini, can I interrupt for a minute?
Like Dr. Vishali said, I've trained in India and working as a senior clinical. Yes.
Your voice is breaking. Dr. Aini?
I'll just see maybe if I share video, maybe that will, yeah.
Probably, yes.
Dr. Vishal, is it better now? Can you hear me?
Yeah, I can hear you, yes.
It's clear now, yes?
It is, yes. Can you make it on presentation mode, the slides?
Oh. Yes, I'll do. Yeah. So we'll start with a brief history of breast localization, as my colleagues have all previously talked about in their previous presentations. So wire-guided localization was the standard of care introduced in the 1970s. In 1988, the ultrasound localization came into being. In 2001, the iodine 125 seed was introduced. And in 2015, Savvy Scout, which is a radar localization technique, was introduced in the United States. In 2016, MagSeed was designed in Cambridge by Endomag in the UK. And in 2017, there is a magnetic occult lesion localization instrument designed in US and Canada, which they call as MOLLY, which was introduced. And the youngest one on the lot is Serious Pintuition, designed again in Europe in 2021. So whenever we have an impalpable lesion, to perform a surgical excision, of course, we need to radiologically localize it to facilitate the surgery. And there are various ways to localize these lesions, and they may vary between institutions. The radiological localization may be achieved by insertion of marker, as said by my colleagues previously, and by stereotactic mammography or under ultrasound guidance. In superficial lesions, skin markers are often sufficient to localize the lesion. Sorry. The oldest localization technique, as we all know, is our guide wire placement into the tumor before surgery, either under ultrasound or mammography guidance. What are the advantages? Is that we already have a trained workforce. It has a high efficacy and low cost. What are the disadvantages? Is that it's an invasive procedure, so there is patient discomfort. It requires a radiologist specialized in breast diagnostics to perform the procedure shortly before the surgery. And there's a risk of displacement. And usually, I remember when I was a trainee and fellow in Tata Hospital, we did it as it was a diagnostic procedure. It was not therapeutic. So we always went back in for the margins, and we always told our radiology colleagues, do not look at the margins, and please just tell us whether the lesion is out or not, and which is fair enough. So we often have to go back in to completely remove the tumor. There are other techniques which have been introduced. So there is radioactive, there's magnetic, there's radar or radio frequency based, and intraoperative ultrasound, which have been developed in the last 2 decades with the aim of improving outcomes and logistics. Intraoperative specimen X-ray is essential to check that the mammographic lesion has been removed. And in case of wide local excision, it also gives us a guide to the adequacy of margins of excision. It is essential to orient the specimen correctly to facilitate this and subsequent pathological examination, and usually achieved by placement of sutures or metal clips, as we saw in the imaging of my colleagues previously. So in 2016, several new generation of localization devices were introduced, like the MagSeed, Serious Pintuition, MOLLY, and Savvy Scout. And we all have to acknowledge that there is a learning curve involved with using all these techniques. There was an analysis from Netherlands that showed that the probe-guided localization is replacing wire-guided localization. It's up from 16% to 61%, and decrease in the use of wire-guided localization from 75% to 32%. I'll start with the radioactive localization. So radio-guided surgery is a wire-free approach to assist surgical excision of impalpable lesions, where we use the standard gamma probe, which is available in our operating theaters. There are 2 forms of radioactive localization currently used. One is the radioactive seed localization, based in the detection of small 125 iodine seeds. And then there is the radioactive occult lesion localization role, which relies on the identification of the pre-injected radiocolloid, which is your technetium-99. I do not have any personal experience with this, but this is the literature that I found. The seed is composed of titanium containing 3.7 to 10.7 MBQ 125 iodine with a half-life of 60 days. It is introduced via needle under sonographic or mammographic guidance into the index lesion, and appropriate incision is confirmed by subsequent imaging. It has a long half-life, so it can be used for neoadjuvant settings as well. Now, intraoperatively, the seed is detected by the standard intraoperative handheld gamma probe, and the area of greatest activity projecting directly over the lesion is easily located to allow the most appropriate incision to be placed. And RSL is one of the best validated wire-free localization methods. It has been investigated in several RCTs and meta-analysis, and I've attached the references below. Coming to magnetic and paramagnetic localization. So in the last 2 years, I've had a decent amount of exposure after moving to the UK with the magnetic and paramagnetic localization. With radioactive material, there are strict regulatory issues involved. So there are several markers that are based on the magnetic detection, which are easier to procure and less hassle for us. So the advantage in such a device is that it allows it to be wire-free and radiation-free for localization. It facilitates logistics for localization as it can be implanted many days prior to surgery. Paramagnetic markers have a small susceptibility to magnetic fields and become temporarily magnetized when there is a presence of an external applied magnetic field, while magnetic markers are always permanently magnets. Metallic instruments often interfere, so we always use plastic retractors. Another factor is that they're not MRI compatible. And in guys, we use MRI to see the response to disease. When we are giving neoadjuvant chemotherapy, we have an MRI at baseline, we have a mid-cycle MRI, and then we have an MRI which is at the end of the treatment. So we do not deploy the MAXID before. Unfortunately, we do it after the neoadjuvant chemotherapy is done, but there is a clip and a coil placed. So we have that as a marker to follow up and then go back in, and the MAXID is inserted before the surgery. So we'll talk about individual seats. So I'm starting with MAXID. This is the one that I'm most familiar with. It was designed by Endomag in Cambridge, UK, but they've recently merged with an American company, Hologic. It is one of the best or well-studied markers. It's 5 into 1 millimeter long, a steel paramagnetic marker, and it is licensed for both use in the breast and axillary placement. And the early studies demonstrated no migration within the breast tissue. We regularly use it for targeted axillary dissection in patients with node-positive post-neoadjuvant chemotherapy. It ensures accurate placement, firm implantation, allows pinpoint detection, and accurate removal. These are just two mammographic images, just to show how the MAXID appears on a mammogram. These are the post-check after the seed MAXID has been inserted. And the small picture on the side is shows us the TAD node. And you need to have a Faxitron or an image, as an imaging X-ray machine is available inside our operating theaters. I've mentioned Cuptake here because that's the one we use. And I think they were recently also available at APSICON. So I think everybody will be familiar with that. Coming to the studies, so the MAXID has the maximum data available, and it is definitely been safe. And I don't think it has a very large or long learning curve. I found it fairly easy to use and got used to it very quickly. So there's a multi-center study from UK, IBRANET, a total of 946 MAXID guided excisions were compared with 1,170 wire-guided excisions. The authors found that the use of MAXID resulted in more successful index lesion removal, 99.8%, versus 99.1%, with a p-value of 0.048, and fewer failed localizations. While it was associated with less risk of dislocation, and the secondary outcomes, which was the minimum margin re-excision, specimen sizes, re-excision surgery, postoperative complications were all comparable. This just to show you what the devices look like. So the one that we are presently using is Gen 2. It just when you can see the probe below. So the probe, when you have it, we usually cover it with a camera cover. And when it is bang on the lesion, you will see this 999 on the screen, which is the Centimag machine. And you know that you've reached the target. And then we go in and we usually try and localize it before we start the surgery. So we know where to look at once we have opened the patient. And of course, you have to see the imaging before any surgery, like we always do. And Gen 3 is still on a trial phase, but the advantage about the Gen 3 machine is that it tells us exactly where the MAXID is and how many millimeters we are from it when we are doing the surgery and looking at it through the probe. I've just put this slide here. This was by Irene. She's done a study which is called MAC Total. So she's looked at about 426 women, and 213 had paramagnetic seed group, and 213 had the guide wire control group. And she found that there were no differences between the paramagnetic seed and guide wire in the re-excision rates and the resection rates as well. Coming to the MAC trace. So MAC trace is a super paramagnetic iron oxide nanoparticle tracer, which is used for sentinel lymph node localization in breast cancer patients, and demonstrating comparable performance to a combination of radioisotope and blue dye. It has an extended role in facilitating delayed sentinel lymph node biopsy in patients with DCIS undergoing a mastectomy, potentially avoiding unnecessary SLNBs. And it can remain in the sentinel lymph node for up to 30 days, providing an extended window for accurate detection and evaluation. As you can see, that comes in a tiny brown bottle, and you have to inject it. I'll just show you a video which will be coming up. So this is a video of one of my colleagues. She was very kind enough to allow me to share it. We have injected the MAC trace when the patient had a mastectomy for a DCIS. We found invasive disease on the pathology, so we had to go back in to perform a sentinel lymph node biopsy. And this is just a very short video showing you how, after we have found the sentinel lymph nodes, she's put the probe on the lymph node, and we're checking for the activity. So how MAC trace has allowed us accurate activity. Accurate localizations of this was the Sentinode study. As I said, we can use it for delayed sentinel lymph node biopsy in patients with DCIs, avoiding unnecessarily SLNB in the first session. And this concluded that marking the SLN with SPO may avoid overtreatment and allow for accurate delayed sentinel lymph node dissection in patients with DCIS. But in this study, they had used radiocolloid and the blue dye, and they compared it and they found that the results were comparable. Moving on to the next one, this is one of the newer ones, like we said, again, designed in Europe, Sirius Pintuition, but it has been used by a lot of institutes in the UK. It is approved by EU for placement for up to 180 days in any soft tissue, allowing for use in both breast and axilla. There is little evidence based on to establish its migration rate, effectiveness, failure rate, cost effectiveness, complication rates, or patient and physician satisfaction. However, there are trials that are undergoing currently in the UK. Again, about Molly, again, very new. The feasibility study is only available of 20 patients which received radioactive seeds together with Molly, and the retrieval was 100% successful. There was a high patient and physician satisfaction, but because there's a small sample size, there's no robust data yet. So just looking at the advantages and disadvantages of all these magnetic and paramagnetic devices that we discussed just now. So the advantage is that there's no radioactivity involved. The marker placement under image guidance, mammogram or ultrasound can be done. It is suitable for localizations of lesions which are visible only on mammography, such as microcalcifications. And localization can be performed days or weeks before surgery. And in cases of neoadjuvant systemic therapy, before the start of treatment, no decrease in the signal over time is reliably detected. And the disadvantages, there are some concerns regarding using it in patients with pacemaker and implantable defibrillators. Also, there's no data available for its use in pregnant women, so it's not recommended. Standard metal surgical instruments often interfere. So like I said, we use plastic retractors, so that's a disadvantage. And it is not MRI compatible, and it is not suitable for lesions that are visible only on MRI. And of course, about the high cost, the cost I've mentioned here is of Centimag machine and the Mac seed, which I've spoken to our UK suppliers, and they said for the Gen 2, it is about 25,000 GBP and about 30,000 for the Gen 3 machines. So adequate localization may be limited in case of large distance between the marker and detection probe, and repositioning after the placement not possible. Also, just one of the points is that it can be used, how we use the wire for bracketing, it can be used for bracketing two separate lesions as well. Coming to SAVI-Scout, which uses the radar reflector localization, micro impulse radar technology introduced in 2015, safe to be used in breast, lymph nodes, and soft tissue. There was a systematic review of 842 cases, which revealed an overall successful deployment of 99.64 and retrieval of a similar rate. And there is a low migration rate of 1.3. I have had some exposure to using Saviscor, but what we find is that they can be the antenna that the seed has can be damaged very easily, either before surgery or during surgery. If it is exposed to too much diathermy, then it loses its, so it makes its localization very, very difficult. So that's the only from my experience. Moving on to radio frequency identification tags, it's promising new technology. It has been approved for breast lesions, not for axillary lymph nodes yet. RFID marker is a small radio frequency tag identified with a small portable handheld device. It displays the real-time distance to the tag in millimeters, and discrete tag identification number discerns each individual tag if more than one was inserted. That was very quick one. Of course, then we move on to intraoperative ultrasound, but I can see we have very excellent radiology colleagues here. And my experience back in India was that everybody was very helpful. And whenever we needed, our radiology colleagues have come and bailed us out in the OT as well. So in IOUS, guided surgery was introduced in 1988 by Schwartz and colleagues. And intraoperative ultrasound is an accurate and effective tool in localizing breast masses and thus facilitating excision. It's also performed using a multi-frequency probe covered in a sterile sheath ranging from 7 to 18 megahertz, and no preoperative localization is required. Advantage is that there is direct visualization during surgery, no radioactivity. You do not need to call the patient prior to surgery because there's no localization done previously. The specimen ultrasound can be performed in the operating room itself. There is exact localization of the closed margins and relatively low cost because usually we have the ultrasound machines available. Disadvantage is that we need to be trained in the use of an ultrasound, and we have to have experience in using ultrasound. There is a learning curve involved. Lesions have to be visible on ultrasound. The use in neoadjuvant setting is limited, and an ultrasound machine should be available, and some ultrasound machines are not suitable for breast ultrasound. Coming towards the end of my talk, talking about carbon suspension, I do know of some colleagues who use this in Europe. So there is a sterile aqueous suspension of carbon powder for a stereotactic marking of occult breast lesions. Tip of the needle is directly placed in direct vicinity of the lesion, allowing the distribution of the carbon suspension over the entire length of the tract from lesion to skin. Again, we'll just quickly go through the advantages and the disadvantages. So there is no radioactivity involved, low cost, localization can be performed days, 2 weeks in advance. Marker placement is possible under mammogram or ultrasound guidance, and no MRI artifacts. Disadvantage is that the marker cannot be localized without surgical exploration. Possible ink migration is there, there's tattooing of the skin. And again, like all the other markers, repositioning is not possible, and a control mammogram is not possible. These are the references, and thank you everybody for your attention and for hearing me. Thank you today. And these are my colleagues back in the UK.
Thanks, Aini. That was a wonderful presentation. I have a couple, one or two questions for you, but I think we should begin with the first speaker,
Yes.
Dr. Jivitesh. I think there was a question for Dr. Jivitesh. Let me read that out for you. Dr. Nityasha wants to know, please tell me the name of second brand other than BARD. I hope she is talking about biopsy guns or the markers. I don't know. Dr. Jivitesh,
Yeah,
can you?
I'm there. So the for biopsy, we use either BARD or Cook, but there are other vendors also like Arrow. But the commonly one which we use are BARD and Cook. But now we've mostly moved to BARD only because we're getting good results with that. And as for wire, there is Copan, which we use, like I mentioned, another one is the BARD. And a marker, we just use the BARD one. We don't have experience with the other one. So this is like a hardware which we use there. And for biopsy, we usually use the automatic biopsy gun.
I think there is probably a concern about non-availability of the markers. Many a times throughout the year, there are some phases when the markers are suddenly out of market. So I think that is why she must be asking this question. So for wire, you said Copan, and I'm sure there are few vendors other than BARD for biopsy guns.
Yeah.
I mean, we can reach out to Dr. Nitya Shah on personal level and can share the names of other vendors. Any other question for other speakers?
I just have a question for Jivitesh.
Yeah.
Have we moved to doing all our core biopsies ultrasound guided, or do you still, are there some, like we, as when I trained, we used to
Mhm.
perform our own core biopsy. So do you still do that, or are they all ultrasound guided now?
It's moving more and more towards ultrasound guidance. Back when I was a fellow, there used to be a
Yeah.
fair share of non-guided biopsies as well for the palpable masses as well. But now, like
Right.
more and more, we're going towards ultrasound guided because see, the complication rates are not much. I mean, but any unnecessary bleeding because some surprise vessel might be there or any other
Yes.
structure which you don't want to injure. Although these complications are very manageable, but best to be avoided. I mean, if the patient goes away happily without any complication, that's the best thing. Quickly can be released after the biopsy. So more and more, I think they're going for guided biopsies only, at
Right.
least
Thank you so
in my
much.
institute.
Can I answer
Thank
this also?
Yes, sir, please.
Yes, most of the biopsies today we are doing an ultrasound guided or maybe MR guided or a stereotactic. Of course, in India, we see a lot of locally advanced breast cancer where almost half of the breast or two-thirds of the breast is involved or ulcerated, fungated lesions. Of course, those patients we do clinical core biopsies. So out of almost 120 core biopsies that we do every month, maybe 5 or 7 we are doing in the OPD. Rest all are image guided, MR or stereotactic or ultrasound guided biopsies.
Yes, thank
I
you. So I
think
used to,
that is,
yeah,
yeah.
yeah.
So that is the practice everywhere, wherever possible and available. It has to be ultrasound guided, but occasionally some logistics concerns may be there, and especially if the lesion is large, palpable, and for some reason, if the radiology, the ultrasound facility is not available, we still perform,
Yeah.
freehand biopsies.
That's absolutely fine because we have a large
Yeah.
patient population, and I have also core biopsied myself in the past. So yes, I
Correct.
completely understand.
Yeah.
Along with the
So
patient.
there is another question for Dr. Jivitesh. Dr. Jivitesh, could you, I know it is difficult to explain, but can you just guide us about the position of the ultrasound probe to the skin, and what is the best position where you carry out, whether it is supine or oblique, or especially if you are if you want to target the lesions which are superficial or deep, or how do you position the patient, position the probe, and how do you angulate your needle, whether it is a perpendicular angulation or you go obliquely. How do you perform an ultrasound guided biopsy?
Okay. So I'll just go stepwise. So first of all, how we keep the patient in the supine position right now, and then we just clean up the patient. It's either with the skin prep or betadine. We usually use skin prep mostly for CT guided procedures. We use the betadine. After cleaning up, like I mentioned, we just localize. We use a probe cover for all the cases so that there is no infection, and then we localize the lesion, and then while giving the local only, we go via the oblique approach, right? I mean, most of us. So you can
Yeah.
go via the center of the probe. I know some old school radiologists who still prefer that way from going through the center of the probe. And but most, I think, everyone today you see will be going from the side of the probe in the oblique way because that is the best way to visualize the needle. So
Right.
when doing any intervention, whether it's deep-seated or a superficial one like biopsy, the golden rule is always to have the needle under your complete visualization so that you
Correct.
don't injure any other structure.
Yes.
So oblique way is the best way to visualize the entire length of the needle. So yeah, so and so like I mentioned, we use a coaxial. Some people prefer to use do biopsies without coaxial as well. There is, I mean, logically, a lot of people might think that the complication rates without a coaxial might be more because you're taking more punctures because every time you go in. But surprisingly, the data in most of the organ biopsies show that the hemorrhage, the bleeding rates are similar. So I guess in the end, it is matter of preference. I always use a coaxial because it reduces the biopsy time. I don't have to go in every time and reach the lesion. So I will finish the procedure fast. So and so with the coaxial inside, I keep the like I showed in the image earlier. We just have to reach the tip of the coaxial and then take a shoot with that. And again, has to be done on an oblique so that. And yes, of course, you have to be very sure how much is the length of the lesion so that you don't overshoot it or go beyond the lesion and hit any other structure like lesions which are close to the chest wall, like and Seema ma'am had mentioned earlier regarding the lesion which can be close to chest wall in MR guided biopsy can cause pneumothorax. So I think she meant that if the needle accidentally crosses the chest wall and hits the pleura, underlying pleura, so that can happen. So just we have to be careful about the throw length also, especially when you're using automatic. In manual, at least you're pushing it manually, and you can directly see it opening under your vision, and you can retract the coaxial or the biopsy gun if you feel it's going to a point where you don't want it to go. But in automatic, you don't have that luxury. Once you press the button, there will be a 2 centimeter throw. So whatever is in its path will get hit. So you just have to make sure the area of interest is in its path, nothing else. So that is how from A to Z I do the breast biopsy.
Yeah, thank you so much for explaining that so nicely and in details.
Right, ma'am.
So Dr. Prerna, coming to you. Dr.
Can
Prerna,
you?
yeah. Dr. Prerna, when it comes to stereotactic, wires, we know that ultrasound is done in a position where we operate. So it becomes easy for you as a interventional radiologist as well as for us as surgeons to, get a overview of where the lesion might be, especially if it is a totally non-palpable lesion. But when it comes to stereotactic wire localization, how do you guide your surgeons? Because it becomes very difficult. When we were colleagues, we used to,
Yes, yes.
sit together and discuss. But how
Yeah.
do you guide your surgeons?
So actually, ma'am, the thing is, as I had said
Not
earlier,
possible,
it's important to be in the same quadrant as the lesion because it is very easy to get carried away with stereotactic procedures. You may end up inserting a needle from the top for a lesion which is located in the lower part of the breast because you're just positioning, you're taking views, it is very mechanical. So we need to make sure that we are in the same quadrant as the lesion is. All right. And communication is the key. We used to, you remember, we would mark out the site, our incision site, you would mark it out and like, okay, you have to place it somewhere in the vicinity of that particular incision site. Right. And in addition to it, we make sure that we are marking the lesion on the skin. So even if your lesion is not exactly, if your entry site is not exactly on the lesion, you mark the skin. And most of the surgeons would cut off the wire at the beginning of the this thing. They cut off the wire and then later on take the incision at the marked site and then remove the wire with the lesion. So with tactic procedures, we are bound to have these looking in London and talking in Tokyo. But yes, communication is the most important thing. And knowing where your incision is likely to be and where where the lesion is expected is extremely important.
Because I remember we have had challenges while putting, stereotactic wires in peripheral locations, especially the upper outer quadrant, it was far difficult for the wire to be placed, and the patient was very uncomfortable. All of that was quite common when we worked together
Yes.
at that time.
Yeah. But
Uh,
communication.
Yes, communication and correct. And going back to the actual mammographic images, revisiting those, and then
Yes,
and
absolutely. We remember we used to share the images of the
correct,
pre-operative images, and that
correct,
helped a lot. We would
correct.
know exactly the pre-operative image, the pre-NACT images,
Pre-NST
actually. You would
images,
look at
yes,
the and see where exactly, the incision was bound to be and where the lesion was in the, pre-NACT images. All those things go a long way.
correct.
I think what we have practiced that in an ultrasound guidance, when we put a wire, it means the lesion is seen on ultrasound. So
Yes,
apart from putting the wire, I asked my radiologist to put a mark on the top of the lesion
Yes, that's
also,
nice. Yes, that's
because the radiologist always tries to put wire in a straight line. But when you actually operate on the table, sometimes the wire may be 10-degree here and there. So if the radiologist puts a mark on the skin of the lesion or the tip of the wire, and then not only that, you should have a good communication every day with your radiologist. Measure the length of the wire which is inside
yes,
and the
absolutely.
marker. I think these two things are very important because wire can be oblique. The measure may be 5 centimeter, but actually the lesion is 4 centimeter from the point of entry. So I think a communication between your radiologist and the surgeon, and if possible, marking is very, very important in look. Otherwise, sometimes you may be in trouble.
correct. And I still remember Dr. Prerna drawing those images, telling me the distance from the tip of the wire to the skin, everything. So, as Dr. Rajiv has rightly pointed out, that it is very, very critical uh, for the clinician, the operating surgeon, and the radiologist to be on the same page and
Like today
understand.
only, I have done a bilateral wire localization, and Dr. Kulveer Elawat has sent me a diagram like this because
Yes.
the wire actually little overshooted the lesion. So he
Correct.
pointed out to me that
Hmm.
from point of entry, this is the distance of the lesion, and this is the distance of the tip of the wire.
Exactly the same way Dr. Prerna also used to do for me. So thank you so much, Dr. Prerna. Dr. Goyal, do you have any questions for Dr. Prerna, Dr. Jivitesh? Okay.
Ma'am, just one thing, just a small
Yes.
thing, not very essential. Sometimes for a deeper biopsy, we follow certain blood work parameters. Just if someone wants to avoid excessive chances of bleeding, they can follow that in breast biopsies as well. For
Mhm.
superficial biopsies, I think the probably INR being about above 1.8 and platelet being below 20,000 biopsies may be best avoided in those. But I mean, if you absolutely want to avoid hematomas and hemorrhages in breast, platelet above 50,000 and an INR below 1.5, and just to make sure that the patient is not on any ecosprin like 150 mg or any Clexane, and those therapies can be tailored accordingly. If otherwise, I mean, mostly it is a safe procedure. If someone wants to just keep, they can have a look at these parameters as well before the
Correct.
biopsy.
Yeah. So, Dr. Aini, one question for you. When we have Maxid and Mactrace both, especially if the breast lesion, breast primary is close to the axilla, say upper outer quadrant, does that interfere the magnetic signal? Does that interfere in identifying the lesion
No,
and the node? How do you manage to do that? So, is there
it
any
does not
difference?
interfere. It will not interfere with the lesion. And
Okay.
I mentioned a paper earlier about irony. So many people do this mag total where they put the seed and they
Mhm.
inject Mactrace as well. So they know
Mhm.
exactly the borders of the lesion. So it helps to remove, you don't excise anything excess, which is just, it marks the stains the entire lesion. And so it's all done under vision and along with the probe. So it does not interfere with any signals. And if the lymph node is there, if it has a mag seed in the lymph node, you can identify them separately. And if you want to remove it, even en bloc, you can do that as well, but it doesn't interfere. It doesn't cause any problems. And
And
like
is
I
there
said,
any limitation, especially if the patient is quite, say, obese, especially when it comes to identification of sentinel nodes? Because when we do ICG, some of the probes have this limitation that the depth of penetration is actually
yeah.
not that good, and it does pose some problem in case if the patient is obese. So, have you experienced any such
Yes,
for?
there is the same issue that comes. We have encountered that if the maxid is there, if it is an obese patient or it's a deep lesion, then you may not get an accurate reading. And sometimes it's better when we have, of course, from the mammogram we have an idea and we localize, and then we go down in the area. Once we've opened, then we're able to localize better. But that is a limitation. Yes.
Okay. So do
Yes.
you only use MacTrace or you use both blue as well as MacTrace? What do you do for
So
sentinel?
MacTrace at Guys, we are using for it's used very rarely. We use it as for sentinel lymph node biopsy. But what we are using it for sentinel MacTrace especially is for sentinel lymph node biopsy in patients with DCIS
Yeah,
undergoing mastectomy to
huh,
avoid a sentinel lymph node biopsy. And
right.
we've done a recent study of 44 patients, but there was 100% identification. We had to go back in 8 patients, which was about 18%, but there was a
Okay.
100% identification rate. We were able to identify the sentinel lymph node biopsy, like I showed in the video. And for
Yeah,
TAD, we are using the MaxSeed. Yeah.
okay. For TAD, you're using Maxid. Okay,
Yeah.
Maxid alone.
Now, Vaishali,
Yeah.
one question about iodine seeds. The
Yes, sir.
half-life is 60 days. While today, the because of the neoadjuvant, effective neoadjuvant chemotherapy, maybe sometimes the tumor becomes invisible after just 2 or 3 chemo. So the duration of chemo becomes 4.5 months. So it may be more than 100 days when you put a seed and when you operate. In fact, it is almost 4 months. So once a seed's life is 60 days, I think it will be difficult to utilize it because the time duration is almost 4 months, 120 days.
So
Yes,
maybe
sir.
then you can put the iodine seed maybe 2, 3 cycles down
Maybe
the
after 2
chart
chemos,
after 2 or 3
with a
chemos.
4 AC and 4 Taxol, the total
Hmm.
durations becomes 4.5 months. And then
Yeah,
you operate 2 to 3 weeks after the last chemo. So the total
yeah,
duration becomes 5.25 months. And
right.
even if you put marker or seed or whatever after 2 chemos, because sometimes after 3 chemos it becomes invisible. The tumor becomes, particularly the smaller tumors, because today the philosophy is in TNBC and HER2, even tumor is 25 millimeter, you are giving NACT.
But I think
Yes,
that is
sir.
not a problem for Maxid, right?
Yeah, that may
No,
not be
that's
a
not a
problem for
problem.
Maxid,
MAXseed,
yeah.
but that may
Yeah,
be a problem for iodine seeds.
iodine seed, yeah.
So, like here in, at least in the hospital where I'm working, they put a coil and a clip. So that is done when the biopsy is done. So the lesion, there is some marker there. So we have a hydrocolloid marker, and they'll put a coil or a clip when the initial biopsy is done, when there's suspicion of cancer or a, like say a B3 lesion. So that the marker is already put in. Sometimes we have patients, we do get results that are benign, and patients complain that why do I have a marker in? But that is the policy of the hospital. So those markers are there, but we are not using, like I said, I don't have any personal experience, or we don't use iodine. I don't know of anybody who does as well, but that was what I found in the literature available. Yeah.
Okay, okay.
So, Dr. Aini, because you've used both wire as well as now
Yes.
Maxseed,
Yes.
at personal level, which one do you really feel is good
We have
in
like
terms of?
yeah. After seeing, I know that we have very expert radiologists, so our guide wires are usually on point. Only once we've had this, my experience with the guide wire was we ran out of theater time, and then we had to admit her because we had the wire in situ. So with Maxid, eliminates all these, but localization, and it's less hassle for the patient. They come in, they feel like they're having another biopsy, is when the
Yeah.
Maxid is put in. So it's a fairly more like from the patient comfort point of view, and then it allows us to schedule the surgery whenever we want, and it is less cumbersome, definitely less cumbersome, and it was not a very long learning curve. But so definitely it is a good product, but once and whenever it will be, I'm sure it will be available in India in no time, very soon.
Yeah. But then what about those lesions which cannot be seen on ultrasound? Then what localization method do you use
So
there in the UK?
similarly, yeah. So similarly, either they'll do it under mammographic guidance or they will do stereotactic, but they are able to put it in. They're able to localize those lesions as well. It's not
Okay.
been an issue so far that we've encountered
Okay.
that they were not able to localize. And sometimes there's a mishap because you cannot reposition it. If it is anterior or posterior to the lesion, then like how we communicate back home, they do the same thing. They call us, they tell us this has happened, or if they know this person is there or going to be there for the surgery, they contact you and they let you know that this has happened. So please take care. And that's how, just communicate. Same issues we have, but we just have to
Yes.
communicate it to each other.
Yeah. Thank you so much. For Dr. Seema, although I personally do not have much of experience with MR guided localizations, but again, because MR guided localizations are done in prone position, which is not the position in which we operate. So how do you coordinate with your surgical colleagues?
So, like I showed you, we always normally put a clip inside.
Yeah.
And then, like I showed one case to you that where we had gone wrong and we didn't really get the sample right. So then we do a hook wire localization under mammography, and that's how they remove
Okay.
that area.
Okay. Okay.
So that clip is basically seen on mammography also very well. Yeah.
Okay.
But Dr.
Alright.
Seema, tell me one thing. We have faced once or twice this problem because we are doing fair number of MR guided biopsies.
Hanji sir.
You do a MR guided web, you put a
Hmm.
clip, and when you take the patients for a sort of mammogram to see the position of the clip, sometimes
It's
the clip
moved.
moves.
Absolutely.
And
Actually, I'm
that's a problem.
also
That's a
facing
problem.
that problem. And so I've also actually put this up. In fact, today I was looking at a thing. We've had clip displacement. We've done about 11 cases and we've had about in 3 cases, which is quite a high number. So in fact, I called the BART guy today and he was saying the clips we are using are not actually meant for MR because they're not available these days. So we are using these clips. But now what we started doing, sir, is when we have done a biopsy, we make sure we do a vacuum and remove as much of the hematoma as possible. Earlier, we were doing it for a shorter time. Now we're removing it as much because it gets displaced because there's a cavity formed there.
Yeah.
And so the clip gets displaced because of that. So if you clear out the cavity well, then the displacement is much, much less.
Okay. Okay.
Yeah. Yeah.
So all right. I think, that makes sense.
I faced the
Correct.
same problem which sir is mentioning, and that's why
Yeah.
we actually went in and looked into this. What should we do right? Yeah.
Actually, what we
Right.
do on the last day of chemotherapy or maybe week after,
Hmm.
we do a mammogram and ultrasound of the same breast. So that we
Okay.
plan whether the clip can be placed by ultrasound or mammogram. If the
Yeah.
lesion is visible on ultrasound, because on the day of the surgery, we have to plan things in advance, whether the patient
Yeah.
is booked for a stereotactic biopsy,
Hmm.
wire placement, or a ultrasound
Hmm.
guided wire placement. So we know in advance whether this lesion is visible on ultrasound or not visible on ultrasound, and then we plan accordingly. If it is not visible on ultrasound, we plan for a stereotactic biopsy because it takes more time. We have to book the ultrasound mammographic machine for that. Ultrasound guided biopsy, there is no problem. We may or may not book even, still we get the ultrasound guided wire because that's a 15-20 minute job.
Yeah.
Correct.
Hmm.
Are there, Sunidhi, are there any more questions? I think there are none. Is there any question from any other person? Dr. Prekshi, Dr. Goyal, Dr. Safalta? So, yeah, Dr. Aini, you wanted to say something?
Dr. Goyal, just saying hello to Dr. Goyal. Thank you.
Okay.
Hi, how are you?
I'm good, sir. Thank you.
So if there are none, then I think we should call it a day. I would like to thank all our esteemed faculty members, Dr. Jivitesh, Dr. Prerna, Dr. Seema, Dr. Aini, for joining us and delivering your wonderful talks. Learned a lot myself, and I'm sure it was a great learning experience for all our attendees. I got to know that at some point there were 105 attendees attending today's webinar. That shows the consistency with which our webinars are received every time. So thank you so much for joining us and sparing your valuable time. I thank all the attendees for being with us and being showing interest in all the webinars, and that actually gives us a lot of stimulation to plan our webinars every month. I thank all my organizing team members. I thank APSI for allowing us to being partner with them to reach out to a large number of people within APSI and all the breast oncology network. I also thank Mighty Duo, the entire team for helping us conduct these webinars flawlessly. There has been no technical glitch. So thank you so very much. And we'll be back with our fourth webinar in the series of masterclass on this series. Very soon we'll announce that. So with that, I thank you all of you for joining us and have a wonderful evening and night. Thank you so much.
Thank you, Dr.
Thank
Shri.
you,
Thank
ma'am.
you.
Thank you, everyone. Thank you.
Thank you.
Record